I just want to, my name is CB Mamrel again, and I'd just like to welcome everyone to our PHSSR Research in Progress series. And we are delighted to have with us today Dr. Fanta Purayidathil, who will be presenting her work and her research on State Health Department and National Food Surveillance Concordance, a pilot study. So while our group here tries to resolve some of the technical difficulties, I just want to go through this this series and talk a little about the pre- and postdoctoral research awards for the 2013 to 2014 cycle, which we had 10 awardees. And these are the one-year mentored research award, and we've had a couple of presentations that have been completed to date. Starting with some of them we'll see in the next few slides, if that can be brought up, from May 14, where we had Chris Malin present on the local health department hospital collaborations in New York State. In June 18, we had the healthcare reform colorectal cancer screening by Dr. Michael Preston. And we had Dr. Teresa Green talking about quantifying the value of public health intervention. In August 27, Dr. Abbas. And a recent one, last September 10, where we had Brittany Johnson talk about improving the HIV and STD partner services in New York State. So if by any chance you missed any of these past webinars or would like to be able to review them or download them, these are available and accessible with the links that are on the screen right now. So just these are available for access. So anyway, please do refer to that. So before we start, I'd like to introduce our presenter for today, Dr. Fanta Purayidathil, who is a manager and health economics and outcome researcher at Boehringer Ingelheim. She recently served as guest researcher at Temple University's College of Health Professions and Social Work while completing her postdoctoral research in health policy management. Dr. Purayidathil's research focuses on notifiable diseases, reporting and health outcomes, particularly in infectious diseases. And Dr. Purayidathil has also taught at Temple University and the City University of New York. So it is with our pleasure, and Fanta, we are delighted to have you, and you have the floor to present.
Thank you very much, and good afternoon, everyone. I hope everyone is able to hear me clearly. I just wanted to spend a few minutes talking about the project I conducted, which was funded by the National Coordinating Center for my postdoctoral research. It was conducted between 2013 and 2014 under the guidance of Dr. Jennifer Ibrahim, who you'll be hearing from later today. And so I'm sure we're all very familiar with hearing about foodborne disease outbreaks occurring either in a regional setting between a few states or at a national level. And it seems, at least once or twice a year, we're looking in the paper and seeing something like this. And so in my dissertation research, I had investigated the rate or the incidence of foodborne disease outbreak at the state level. And we saw some variable numbers. And so the next question that I asked was, well, what might be influencing these numbers from a structural perspective or from a policy and implication perspective? And so I wanted to get an idea about how the information gets funneled on foodborne disease outbreaks between state health departments and the CDC, who is nationally collating this information, cleaning it, and then making it available for policymakers and for researchers like myself to look for ways to improve public health. And so the study objective was basically to collect the means by which state health departments gather the information on reportable diseases specifically related to food safety and compare them to that list which is maintained by the CDC. And so you see here the official objective was to characterize the informational and organizational structural capacity of state health department foodborne illness reporting systems through comparison of a single channel for food safety surveillance and data collection, specifically the notifiable disease lists that are maintained by each state. And so what I did was I accessed the Council of State and Territorial Epidemiologists online database, which is a warehouse for all of the notifiable disease lists in the United States, all 50 states. And I also did some double checking just to make sure that it had not been updated recently, because the rate at which states, the health departments were doing that is variable as well. And then I compared all of those lists that were most recent to the 2011 CDC's list of nationally notifiable diseases. And I want to point out that if the list was developed after 2011, I did not include those state health department lists because it wouldn't be a fair comparison to compare those to lists that were not developed around the same time. And so those were pulled, and all of the vectors or conditions that were associated with foodborne illness, so Salmonella, E. coli, hepatitis A, were pulled from both sets of lists for each state and compared. And so what I did is I looked for the existence of a particular pathogen, norovirus, Campylobacter, Toxoplasma, on, for example, Alabama's state health notifiable disease reporting list, and the CDC to look for concordance. And you can see here on the slide, this is the complete list of the pathogens that I was investigating for this study. And so the data, once it was all collected from all 50 states, was cataloged in this way. So whether or not the pathogen was included on the state list was noted. How many in total pathogens were concordant between the CDC and the state health department list. I wanted to get an idea of the year in which the list at the state level had been updated to get an idea of how frequently these lists are being evaluated and potentially updated. The category of food outbreak was added in 2011 to the CDC's nationally notifiable list, and I wanted to get an idea of the presence of that category on the state list, or if they were breaking everything down by pathogen and collecting the data that way. I wanted to see if I could get an idea of patterns geographically. So were states in the Pacific Northwest, for example, more concordant with the CDC list than states elsewhere? General concordance with the national list, as I've described. And then I wanted to link the pathogens that were most associated with healthcare resource use. So Toxoplasma norovirus tends to result in a greater incidence of hospitalizations than some other conditions might. So I wanted to take a special look at those. And so what we found was very interesting. All the states have a list, which is good news. Every state collects a series of notifiable diseases related to food safety and other diseases of interest, mostly infectious diseases, but some chronic as well. Only 26% of, 26 or 52% of these were updated between 2011 and 2013, which was interesting. A lot of these were much older lists. Some were from 2009 or 10, and as public health professionals and researchers, we understand how flexible public health maintenance can be. So that was interesting. 12 states maintain a separate list for healthcare providers versus laboratories. So when a state health department develops these notifiable disease or reportable disease lists, sometimes they were for all comers. So if you were a pharmacist, if you were a school, if you were a healthcare provider, the same list was filled out. But in the states that are highlighted on this slide, there was a separate list for healthcare providers and labs. So if information came through one channel and not another, it could still be captured. About half of the states collect data on foodborne outbreak in general. So that is included as a general category on their list. And then at least 70% concordance was found in only a handful of states, and the percentages never went over 90%. So California had 85% concordance with the CDC's list. Florida had 78%. Ohio had 75%. Rhode Island, 75%. Connecticut, where I'm living now, 71%. Delaware, 71%, and New Hampshire, 71%. All of the other states were under 70%, some as low as 50%, concordance with the CDC's list. And so when I needed to interpret the data, and I'll go back to this slide for a second, what does that all mean? And why is the concordance so variable between the CDC and various states? And just to clarify, the darker the color on this map, the greater the concordance. And so you see in certain parts of the country there's very strong concordance, and in other parts it's not very strong at all. My first thought was, why is that? And I had the privilege of presenting this data at the Keeneland conference this year, where there were several public health practitioners representing state health departments in attendance. And I actually was fortunate enough to talk with some of the personnel from the Connecticut State Health Department. And some of the feedback that I got was very interesting. The first thing they said is, we understand that there is a lack of concordance or variability in concordance with how much the CDC's lists look like the state health department's list. There's a reason for that, though. Sometimes there are regional pathogens that have to be considered, which makes sense. But the thing that really struck a chord with me as a health policy researcher was that they described that states' health departments have very different ways from state to state by which to update the list. So it's not just a matter of, oh, we see an outbreak in this pathogen, or we're seeing, for example, we are all, I'm sure, aware of the challenge we're facing with Ebola right now. It's not just a matter of adding it to the list and then redistributing it or recirculating it amongst all the stakeholders. Sometimes there's a steering group that has to meet and determine whether or not it's appropriate to add this pathogen to the list. And sometimes that takes a considerable amount of time, or it results in the pathogen not being added at all. In some states, legislation must be passed in order to update the list. And sometimes there are temporary high-profile conditions like the Ebola that I mentioned, where it's not added as a notifiable disease to the list because it's recognized as a sort of temporary situation that needs to be addressed, and there is a different channel by which to address that challenge and outbreak. And so I was really happy that I had the time to spend talking to practitioners and what their thoughts on my research was, because it just gave me more questions. So now I'm interested in investigating which states have which process by which to update their lists, and how might those processes be aided or streamlined so that these states can better keep up with the CDC. And perhaps the states are actually more advanced in identifying these pathogens that need to be added, and maybe there needs to be some more collaboration with the CDC to make the CDC's list more concordant with the states instead of the other way around. And so it was a very interesting pilot to complete. As usual with research, I ended up with more questions than answers, but I was really happy with the project in that at least every state is collecting information and has a channel, a formal channel by which to get this information collected and eventually passed on to the CDC. And I just wanted to end with a quote from a champion of food safety policy and legislation, Darrell Issa, who is a representative out of California, which coincidentally had the greatest concordance with the CDC's list. So again, I would like to thank the NCC for providing me the funding and the opportunity to pursue these questions, and I believe you'll hear from her in a few minutes, but Jen has been very involved and very aware of my interest in this area and very supportive, and so I'm very grateful to her as well. Thank you, and please let me know or let the moderator know if you have any questions.
Thank you, Fanta. Excellent. Thank you for sharing your work and for the presentation. And before we hear from your mentor, I would like to introduce first your mentor who will be commenting on your research, Dr. Jennifer Ibrahim. Dr. Ibrahim is an associate professor and the associate dean for academic affairs in the College of Health Professions and Social Work at Temple University, and also the associate director of the Public Health Law Research Program. Dr. Ibrahim's current area of research focuses on the intersection of public health systems and services with public health law, as well as her ongoing work in the area of state and local tobacco control policy. Jennifer also teaches coursework in the public health policy and research methods that support rigorous and systematic empirical evaluations of public health laws. We're also delighted to have with us today Dr. Ibrahim to comment on Fanta's research. Jennifer, you have the floor.
Great. I'm not sure who has control of the slides, but is it possible to flip back to slide number 3, the system for reporting? Perfect. Oh, go back one. Perfect. So I think there were a lot of different pieces that came out of this study, and I think Fanta did a fabulous job with this. For me, this was really interesting to be working on. As was mentioned, a lot of the work that I'm doing is also in the context of public health law and looking at the legal authority for health departments to be actually carrying out these different activities. And so it was really interesting as Fanta was looking at it from a systems perspective for me to be thinking about it also in terms of the legal perspective and some of the obligations that we have. I think this diagram is very appropriate in terms of reporting or depicting the way that we should be reporting, but in actuality, a better way almost to depict this is actually if these were each puzzle pieces. Lots of things have to go right in order for the health department to be getting that data and being able to report that. So we were really focusing on one piece, looking at the concordance between the CDC and the health departments in terms of what's being reported. But I think it's important to keep in mind that having that list, the existence of the list, sometimes can actually be camouflage, because just because the list is there, it doesn't necessarily mean that that information is accurately being collected and reported. So there are some issues there, looking at the relationship between state and local health departments, between physicians who are, patients are presenting to physicians with these illnesses, and the way that all those different pieces come together. So from a PHSSR perspective, I think there's some additional work that can be done looking at this quote system to see where some of the breakdowns are. In a practice perspective, and I would just caution that there is that concern of the camouflage that we have a list, and sometimes folks can assume that because the list is there that the reporting is occurring, and that's not necessarily the case. The other thing is appropriately noted by Dr. Purayidathil that the evidence is a really important thing here. Thinking about when these lists are being updated and how responsive these lists are to emerging threats. So being able to link these lists in, with also public perception. A lot of times what we see on the news is what the public is believing to be the absolute truth, and a lot of time it's being sensationalized. I think it's important that as these issues are coming out, can you hear me?
Yes, Jennifer, we can hear you. Go ahead.
Okay, I got cut off for just a second. I think my other line was ringing.
No problem.
So it's important that we think about the evidence base in terms of what's on these lists and what we're reporting. We know that health departments have limited resources, and so are we really tracking what is most vital in terms of the population's health? Another thing to be thinking about here is also what we're focusing on here is when an individual is presenting as being ill. And there's also great opportunities for PHSSR in terms of working with non-traditional public health partners and thinking more upstream. If we're trying to prevent food safety issues, if we're trying to prevent foodborne illness, there are ways that we can be working and thinking about how to take a systems perspective, including the public health side and private corporations, food farmers to distributors, manufacturers, et cetera, to be more preventive. And so there's some work pulling in technology, actually looking at ways that we can be tagging food in such a way that as the food is contaminated, whether it's spoiling or it's been infected, it's been exposed to a contaminant, that we can actually be tracking that. And there are some experiments going on being able to track that information and conduct surveillance that way. So instead of waiting for people to show up at a doctor's office sick, where the health consequences have already and the economic consequences have already been realized, there are ways that we can proactively prevent this food contamination as well. And so I would just caution that this is focusing on one piece, but when we talk about food safety and foodborne illness, it's part of a much larger system. And so I think there are some really good opportunities to be thinking about how we can operationalize that, the mechanisms that we could be looking at for the way those entities are connected. And I think that feeds back in with the agenda that PHSSR sets forth for folks who are looking to engage in PHSSR in terms of the system structure and the performance. The one other thing I just want to say with regard, and this touches on the workforce piece, is looking at the turnover that we know we have in health departments and thinking about the level of awareness that folks in health departments have with regards to this reporting. And so Fanta didn't touch on this in her research, but not just looking at the documents in terms of the concordance, but also getting to the folks who are actually collecting this information and reporting this information, their level of awareness of what is supposed to be reported as opposed to what's the urgency of the moment. So I think there's a lot of different opportunities. I think this study is really a starting point for, it really opens the door for a lot more work in food safety. And I know this hasn't traditionally been a major area of research for PHSSR, but I think there's a lot more that could be done.
Thank you, Jennifer, for those insightful comments. And before we open the lines for questions, we'd like to give Fanta, I guess, an opportunity to maybe add on to the comments that Jennifer provided. Fanta?
Yeah, thank you. I really like the puzzle analogy. I think that that's great, and that really is exactly how we should be looking at food safety maintenance and food safety protection from a policy perspective. There are so many moving parts, and some of those parts are engaged with each other formally. Some are more ad hoc, for example, in the case of an outbreak, and some of those engagements never take place. And I think that for food safety in particular, it's really important to think of all of the stakeholders as parts of a puzzle piece. And when we're conducting research, to think about that as well, because the actions in one area are certainly going to influence the action in another. And Jen and I have done research together in food safety in other areas, and we have seen that to hold true. So thanks for that.
Thank you, Fanta. So we're going to open now the lines for questions. You guys can use either the chat box, you can type in your questions, or feel free to just introduce yourself and ask Fanta the question. All right, let me get started so people as they prepare their questions. So Fanta, moving forward, how has sort of the results of for this particular research been used, or what are sort of the steps moving forward now, or the plan moving forward with this research of yours?
Well, as I described, I was able to present this research at the Keeneland Conference in April and connect with representatives from the Connecticut State Health Department and get their insights on how the processes and personnel, as Jen described, and other elements might influence these lists, and how much of a camouflage these lists are. What I'd like to do in the near future is continue to connect with practitioners from state health departments to identify more of the stakeholders in this and see what their relationship is to the process and the system and the structure, and research those more closely before getting to the point of identifying solutions. I think that in this area we're still information gathering, and so I'd like to be able to pursue that going forward.
And this is Jen. I think one of the other things that we've talked a bit about is actually being able to do some econometric studies here, looking at what are some of the costs associated with this illness, and being able to do some predictive modeling around the costs of not reporting. And so if reporting isn't going on, are there missed opportunities in terms of preventing additional illness? And unfortunately, money talks. And so if there are ways that we could make the case more urgent by matching it up with some dollar figures, I think that's another big area for research that would be important to carry out.
Thanks. We have a question from Julia who says, it is difficult to assess the effectiveness of various sets of reporting requirements if we don't know what proportion of incidents is missed. Do you have any ideas about how to estimate the missed cases?
Fanta, did you want to talk a little bit about...
You mean the cases that are not reported?
I think the question, refers to that, where the proportion of incidents is missed. So, I mean,
right.
Yeah.
Fanta, do you want to talk a little bit about the
unreported cases? Correct. Unreported cases. Julia just gave a clarification. Go ahead.
I was just going to say, Fanta, do you want to touch on the looking at the different data sets in terms of reporting? There was another piece of the project that Fanta didn't report on here, looking at the H-cup data.
Yes. So one of the ways that the reported data can be collected is through healthcare claims, if the patient has to go to the doctor and receive treatment, or if they need to go to the hospital and their primary diagnosis or secondary diagnosis is listed as a foodborne pathogen or a specific or general one. That is well understood to be a less than ideal means, but if we're looking at reporting from state health departments and knowing that 95% of those cases that actually do occur are not reported because people either wait it out, they do not have insurance, or it's just not noted by the physician in the claim that gets sent in, we can use the H-cup data or healthcare claims data as a proxy measure. There are other technologies that are being developed by which to better capture these cases that we know go unreported. For example, in Utah, they developed a reporting system for consumers or for patients. And so if you eat something and you feel that you're unwell and that it's related to the food that you ate, you can go to the Utah Health Department's website and submit the claim that way. So you don't have to wait for a lab or a physician to do it, and you don't have to seek formal care that would be captured in a claim. But in terms of really getting an idea of the number of unreported cases, there are a few studies, Sheriff has done a couple, where they have estimated the likely rate of unreported, and it is considerably high. I hope that answers the question.
And I think the example that the analysis that Fanta did using the H-cup data is a really good example where a lot of times we're depending on the public side of things, and better partnerships between public and private entities is really going to be a key to doing a better job with food safety issues. Looking at the data from physicians, we see that that's one way that we can start to capture these missed opportunities. But even in terms of the prevention side, I'll just use the example of Costco. Costco has a system where every single person who's going in, they have these membership cards. And so if there is any type of contamination, they have a system where they can alert both via email and via telephone any consumer who purchased that product, a recall for them, for folks to bring food back in for a refund, or at least not to consume that product. So I think another big opportunity with M.P.H. SSR is for us within the public health realm to think about these non-traditional partners, some of the private entities, in terms of being able to quantify this and also to prevent this. So the H-Cup study was just a really nice, Fanta didn't get to present it here, but I'm glad she had the opportunity to talk a little bit about it.
Yeah,
Thanks. And yes, the Costco example is a really, really good one, because as we talked earlier about still needing to quantify the problem and really needing to just completely describe the problem, we're going to need to look at different and unconventional means by which we can collect data, and the Costco example is a great example of that.
I think that answer segues nicely into this question from Jillian in the chat box. Hi, Fanta. As you reviewed practice in each of the states, did you get a sense of which models were most successful from the perspective of both quickly identifying incidents of known pathogens and rapidly surfacing newly emerging pathogens?
So give me a moment. I'm just rereading it to make sure I understand which models were more successful. This study in particular looked at one model of reporting, so the existence of the list and the concordance with a static example or the CDC's list. But what I think you're getting at is maybe did we find that there was better concordance or better reporting in states that had multiple channels versus a single channel? How the list is developed in each state. I would love to do a study that investigates how the lists are developed in each state and maintained in each state. The comments that I got from those public health practitioners in April after I presented this, they were the ones that brought that up, that in some states the lists are developed by steering groups and in others there's legislation passed. And it would be a very interesting question to investigate what the process for developing the list has on the likelihood of the list being concordant with the CDC or the likelihood of the list being implemented well, in that they're receiving a higher incidence of foodborne outbreak. And also investigating if there needs to be multiple channels. So in the states that received different lists from labs and physicians and schools and pharmacies, do they have better rates than states that don't? Those are really great questions. Thank you.
Are there any more questions? You can also use if you're connected via the phone line, please feel free to introduce yourself and ask a question, or you can also use the chat box. Great questions from Jillian and Julia. Thank you for those. Well, I guess everyone's still trying to take in much of what you've presented, Fanta. So once again, we're really grateful for the time that you shared. And also thank you, Jen, for also the comments that you've provided. So we'd like to bring up the next slide for the upcoming webinars. So please don't forget, we have on October 8th, the next one, which will have Dr. Simone Sin, who will be presenting on the variations in the cost of delivering public health services and analysis of local health departments in Florida. And also, please refer to the schedule of other upcoming webinars. And I think we could go to the next slide too as well. And so we will get reminders, and we hope to also see you there. Again, we'd like to thank our presenter, Dr. Fanta Purayidathil, for her wonderful presentation, and also for the comments from Dr. Ibrahim. Thank you as well for being with us as well today. So we'd like to thank everyone for joining us today in our webinar series, and we look forward to seeing you again next time. Thank you, and have a great afternoon.
Thanks,
Thank
everybody.
you. Bye-bye.